Chiropractors, today we're going to be discussing the pelvic adjusting done in the side posture position. We're going to go through a lot of setups today. So to save Joe's back, we're going to talk as much as we can before we get into the actual setup. Let's talk about preferred moves. Okay? Push versus pull. PILM, preferred push or pull? Push. AS, push or pull? Push. Okay? IN, push or pull? Push, and the only one that's preferred pull is what? The EX. EX. So let's go through the compound listings. PI5, IN5. So it doesn't matter what the subscript is, right? Any PIIN will be a preferred push move. Any ASIN, regardless of what the subscripts are, going to be preferred push. Everybody have it? Okay. How about a PI5 EX10 preferred move? Pull, PI10 EX5, push, AS5 EX10, pull, AS10 EX5, push. Okay? Now, take that next step. We have to think outside the rules a little bit. An AS2 IN10. Now, preferred move is a push, and you're contacting what? What would be the segmental contact point? Ischial spine. But think about it. Long lever moves versus short lever moves. Which will get more correction? Short lever or long lever? Short lever always wins. So, going to the clinical basis. If I have an AS2 IN10, my first step, if the patient has a sacroiliac subluxation, I would probably adjust them as an IN contacting the PSS for 3 out of 4 visits when they have that SI subluxation. Then every 4th visit I might drop down and do an ASIN. Because I'm going to get more correction on that IN, okay, by the PSS than I ever will on the ischium. Everybody understand that? So it's not just a matter of I have an ASIN, it's how can I make the best correction on that patient. Same thing if I have an AS2 EX10, okay, you think I'm going to get more EX correction out of the ischium contact or PSS? PSS. So again, probably 3 out of 4 visits, I might come up and do an EX pull to correct the EX. Then every 4th visit come down and do the ASEX. You understand the difference? Okay. Because you could have an AS1 IN10, that AS1 might be from your pencil not being sharpened that day. Okay. And remember how we always use the double checks. Double check the obturators. Does it really look like an AS obturator? It may not really be an AS. It might just be your pencil drawing that day. Everybody follow? Okay, so it's very important to understand the adjusting rules. The other rules you learn are when to adjust an ilium versus when to adjust a sacrum when we have a rotated sacrum along with an ilium subluxation. Because it's a sacroiliac joint. So there's some people say, well, let's move both. Well, you can't. It's one articulation. You're moving one forward or one backwards. Everybody understand? You're always trying to line up your auricular surfaces, of the sacrum and the ilium so they have optimal relationship. Okay? So let's say a P-R along with the following examples. Okay? P-R along with an ASIN with any subscript, I'd adjust what? Sacrum ilium. Okay? The sacrum, just the sacrum. If I had a P-R along with a PIEX with any subscripts, I'd adjust what? The ilium. The ilium. Remember, major S, major IN, we adjust the sacrum. Major PI, major EX, we adjust the ilium. Everybody have it? So P-R along with these other examples. PI5, IN10. What do we adjust? With a P-R. Sacrum. PI10, IN5. Ilium. AS5, EX10. Ilium, AS10, EX5. Sacrum. Everybody have it? Everybody have it? Okay. Now, we're always going to start with perfect patient placement, but before we do that, I want you to visualize the sacroiliac joint. Once you get in your mind's eye the shape of that sacroiliac joint, it becomes a lot easier to adjust. I'm going to stick the critique card in the SI joint. If I'm doing a PIN, I have to make sure my arm is thrusting in relationship to that sacroiliac joint. So, The doctor's stance is always going to be the same. I'm going to be close into the bench. I'm going to be rolling that patient over quite far for PIN so I can drive what? Medial to lateral. Medial to lateral. Everybody have it? Okay. So you have to think about the shape of that joint. A lot of people aren't driving through the articulation. Then you also have to consider male versus female pelvis. Okay? Male pelvis, the SI joint, sit approximately at a 45-degree angle. Female pelvis, they're more oblique. The pelvis looks like it's looking at you. It's wide because it's about a 60-degree angle. So the female pelvis is going to look more like this. So obviously this is what type of pelvis they have. Male. Everybody have that? So think about your line of drive on that male versus female pelvis. And can you have a male pelvis and a female and vice versa? Absolutely. So think about the body build that you have in that particular patient. Okay, Jill, get your good side, please. One of your slacks just below PSS. Again, we always start with perfect patient placement. First step is going to have the inferior leg foot off the end of the bench. Superior leg flex, toe end behind the knee. And make sure it's shoe shine tight. Not just getting close, you want it in there tight. If you have it back like this, you try to do a pull move, you get all this slack. So make sure that toe is in tight behind the knee. Then, we're going to scoot the patient back on the bench. Big time. Just go here. More. And we're going to tuck that pelvis so we have the lateral thigh parallel to the floor. Okay. You have somebody with a long femur like Joe, you have to do a little more tuck than somebody that's shorter because there's a lot of weight in that leg. So we have to make sure he has no sense of rolling. If his knee is pointing toward the floor, he's going to have that sensation of rolling. If he has that sensation of rolling, he's not going to relax. You won't be able to achieve the adjustment. Then, to fix the shoulders, always make sure you lock in the patient's knee, grab their ilium. Okay, bring that shoulder back underneath. We start them shoulder on shoulder, then we pull the bottom shoulder inferior, slightly anterior to the top. We have the point of the left elbow going down the side of the body, so it's behind midline. Then the other hand just fold across the forearm, patient's looking straight ahead. The long axis trunk is always parallel long axis of the table. So he should feel balanced. He shouldn't feel like he's falling at all. If he has any sensation he's rolling, start over. Everybody have it? Now, think about the tissue pull. We try not to dig into the muscle in the lumbar spine because it can cause muscle contraction. Do we have muscles at the sacroiliac joint? No, it's all ligamentous. So we can get a very aggressive contact. So you can take as firm as contact as you want, and you don't have to worry about muscle contracture on that PSS. So, going to a PIIN push. We're going to start with a wide stance. My inferior leg will touch the patient's knee, my superior leg will not. Because when I roll the patient toward me, my center of gravity, my belly button, has to be over that segment, and my weight has to be distributed equally on my feet. So we find the medium inferior portion of PSS. We always take tissue pull to the SCP. Common error is people start the SCP and take tissue pull and end up going across the joint. So you always end up on the SCP. So we take a strong tissue pull, medial to lateral, strong roll in. So my fingers end up pointing toward the crest. I'm going to do an actual contact just once to joke and feel. Then I'm going to stick his shoulder superior until I feel it pull underneath my hand. Feel that, Joe? Now we're going to back off with both hands. Then, once I take that contact, I roll him toward me so I can get a medial lateral line of drive. Am I going to step back further? No, you stay in close. I'm just going to catch him with a lower portion of my thigh. So again, I've pinned him between my anterior thigh and the bench. My contact is here. I'm driving medial lateral, P to A, torquing down the articulation, also I to S. Notice my belly button's right up over it. Now I could get that same line of drive by being in this direction. How long will my back last? Okay. Now I have enough upper body strength, I could probably pull this off for 2 or 3 patients. But you won't be able to adjust all day. So again, get that patient to your center of gravity, okay? Then you can take it. PIX. PIX. Think about the bodybuilding for patients for INs versus EX. Do we have more tissue lateral to the PSSs or medial to the PSSs? Lateral PSSs. So for EXs, we're always going to take more what? tissue pull. And that's a key point. We have a lot of people in that tissue pull end up on top of the PSS with PIXs, and they thrust and they hit the sacrum. So take your tissue pull starting lateral to the PSS, take tissue pull to the PSS. All these are going to be modified arches. So I find lateral inferior portion of PSS, I take tissue pull lateral to medial, I to S. Initial contact, my fingers are running toward the patient's crest, and then I roll in so the fingers are pointing toward the down crest. So we're going to be torquing up the articulation for a PIX. I'll back off the tissue pull. Again, we stick the shoulder superior. As we go throughout the hour, I might lose Joe's shoulder. It's just hard to lay here for the entire hour. But just pay attention from the waist down. I'm going to roll Joe toward me to a comfortable working height for me. Well, I have to roll him over as far for an EX. Not in close. Once I get him to that working height, I sidestep, placing the anterior portion of my thigh and lateral portion of the patient's thigh. I get my arm out, so I'm thrusting P to A, I to S, and lateral to medial. Common error people have on PIX is having their arm up close to their body, and I don't have any P to A. So make sure you get that arm out for the P to A component. I'll set P to A, I to S, torquing up the articulation. Again, tricep pec to body. Get your body weight forward, balls your feet. Be springing on my back toe, bending my front leg. Now again, we always want to make sure that we're going to have the segment in motion the entire way. So if I was doing adjusting thrust, I stick the shoulder up, roll, catch, thrust. Roll, catch, thrust. So I'm not going to just stand there in a pretty pose and then try to thrust with my upper body. Okay? We're saying his entire body in motion. I stop his trunk motion. I finish with a tricep contraction to shear the SI joint. So basically that PSS never stops the entire way. Any question on PIX? AS push moves. We're going to discuss the AS IN, ASDX. We're going to palpate for the apex of the sacrum and the rim of the acetabulum and split the difference. And that will put us right over that ischial spine area. We can't palpate the ischial spine, but that's where we want to end up. Now, patient management. Okay? We're not just going to grab the patient's pants and rip them down. Okay? We'll palpate the apex sacrum, acetabulum rim, say, lower your slacks for me, please. Get in the habit of that, because you're in class, you're working with friends that you've been with for a couple of years, and we have that habit of helping each other out. Get out of that habit when you come in the patient population. And you won't have any difficulty with that. The average patient will lower their slacks lower than what you would if you intend to do it. Okay? People come to doctors, they expect that you're going to be touched when they go to a doctor. So you won't have any trouble with that. Just palpate the part, say, lower your slacks for me, please. I palpate the apex sacrum, acetabular rim. For all AS push moves, I want to make sure I take a strong what-to-what tissue pull. S to I have to take out all that slack. Now Joe's pretty muscular, so we don't have a lot of tissue pull. But we have a lot of people who don't have a lot of muscle. We have to take all that S to I slack out, or we won't have a chance on AS type push move. So palpate apex of sacrum, acetabular rim, and take a strong S to I tissue pull. For ASIN, come in with a roll in, actually start the fingers back toward my body, spin till I have a 45-degree angle on my hand. Joe can tell you that tissue is taut. There's no slack left in there. I'm going to back off. We stick that shoulder superior again till I feel it pull underneath my hand. Now, here's the difference. For PIs, we just have the toe tucked behind the knee. For AS push moves, we're going to nudge it up just a little bit. As I nudge it up, what will that do to the PSS? Rocket what? Posterior and inferior. Do we want to rocket posterior and inferior for PIs? No, we have to have it at neutral position so we can set it P to A. So it's just a little nudge. You're never going to go past 90 degrees. Stick that shoulder superior. I roll the patient toward me. Now I'm going to maintain contact on the inside of my knee to keep that leg stuck up. Everybody have it? Then I sidestep superior, keeping that contact, keep that leg up, getting my center of gravity up over that patient. My forearm's driving down the femur head, so I'm setting S to I, P to A, torquing down the articulation. This way. Everybody have it? ASDX. Same strong SI tissue pull, but this time I start the fingers pointing toward the table and I roll in until the fingers point toward the down crest. I stick that shoulder superior. Again, since it's AS push move, I'm going to nudge the knee up a little bit to rock that PSS posterior inferior. I roll the patient toward me, maintaining contact with the leg. I sidestep, place the anterior portion of my thigh, lateral portion of the patient's thigh. Again, notice my center of gravity is right up over the pelvis. My forearm shooting down the femur. I'm setting S to I, P to A. At the very end, I torque up for EXs. Now, we're going to show you the stabilization on the other side. Joe, if I could turn over just a second. Now, here's our doctor's stance. Notice my left leg is touching, right leg is not. For PIs and lumbars, we're going to roll the patient over, sidestep, placing the anterior portion of my thigh and lateral portion of the patient's thigh. So when I push on that PSS, his belly's going to come forward. If I push on lumbar, his belly's going to come forward. AS push moves, the AS push, ASIN, ASDX. All I do is shift my weight up a little bit, step his knee up. I maintain contact as I roll him over, sidestep, cover. Everybody see the difference? Just lean back. Any question on PIN, PIX push, ASIN, ASDX push? Okay, the pole moves. Pole moves, again, pole is a bad term, it's a finger push. Finger push. Now, for lumbars, we taught you how to stack the fingers, so you're getting on that real small segmental contact point. We have big points down here in the pelvis. So if I'm doing a PIIN pull, I'm going to place my chiropractic index finger on the medial inferior portion of PSS, my ring finger on the inferior portion of PSS, my forefinger on the medial portion of PSS. So I have the entire segmental contact point surrounded. Everybody have it? And again, we can get aggressive with PSS contact. Okay, if you ever baled hay, it's like having a hay hook. You're going to hook right into that PSS. Good firm contact. Again, you always start with perfect patient placement. So PIN pull, I take a strong tissue pull, P to A, I to S, medial to lateral. When we finish with the strong roll in with the clock. Again, Joe can tell you we're hooked on there. So very firm contact. Okay. This is the adjusting hand. This is the stabilization leg. A lot of people pretend that this is the adjusting leg and this just lays there. The hand does the adjustment, not the leg. The leg is strictly a counterforce for your thrust. I stick the shoulder superior till I feel it pull underneath my contact hand. Then I bring my knee right below the ischium, the shin and the angle of the knee. So the pressure Joe should feel is on the back side of his distal tibia, and I'm going to thrust while I kick toward his belly button. So basically my shin and my fingers are going to meet in a coordinate probably just below his belly button. There's going to be the thrust. P to A, I to S, torquing down at the very end of the thrust. Notice my center of gravity is way up over him. If I step back, I'm going to roll him toward me, and I'll never be able to get the adjustment. So again, the stabilization leg is that. Stabilization, it's counterforce. Any question on PIN pull? going to do the EX pulls, okay, PIEX and ASEX. The adjustment for this is going to be what we call an elbow whip. We're going to be using the pisiform, or the hamate, for a segmental contact point. If you can just whip that elbow to your side, if you'll notice the hand comes up automatically. So PIEX, all I do is get a little more elbow bend, ASEX. But try to whip the elbow to your side. You know, just pretend your uncle's coming up behind you, tickling your ribs, and you want to stop it. Boom. Just whip that elbow to your side. It comes up automatically. That's where you generate speed, is whipping that elbow toward your side. If you look at all the preferred moves, PIN, ASIN, PIEX, ASEX, what's the common denominator? Elbow's always whipping into your side. Everybody have it? Everybody have it? So you don't have to worry about anything. Okay? You just think about bringing that elbow whipped into your side and you'll be in good shape. Now, keep in mind, on the patient, you're never going to get that far, but that's the direction of your thrust. Now, PIEX is a move that you either get or you don't. Okay? If you have great patient placement, it's one of the easiest moves to do. If you have bad patient placement, it is virtually impossible to do. So pay attention to what we're going to talk about as far as patient placement. We always say with patient placement, the greater trochanter is tucked anterior on the bottom leg compared to the top. So I have the right leg, it's against the bench. I have the pelvis tucked underneath. The right greater trochanter is anterior to the left. That's going to place the PSS where in relationship to the table? It's going to be right on it. Everybody have it? What I'm going to do is I'm going to have Joe lift up. I'm going to place my hand underneath so my thenar starts in that lateral inferior portion of PSS. And then my roll in and tissue pull are one and the same. I'm going to roll in clockwise, replacing my thenar with the hamate, so that my hamate is hooked in that lateral inferior portion of the PSS. So Joe will literally be laying on my hand. Everybody have it? If I can make any type of spastic jerk to get my hand out of there, I'm probably going to adjust it. But if you lean on that patient's leg a little bit, now you have to hold your hand there, and you probably won't be able to adjust it. So make sure that patient's always laying on your hand. So you have to have that perfect patient placement with that lower hip tucked anterior to the upper hip. Scoot back to the bench a little bit. Now I'm going to have a lot of tuck to make sure his PSS get there. So I start him toward the middle of the bench, then I'm going to swing his lower hip underneath. And if you want to err in any direction, over tuck. Because you can't have any sensation of that patient coming forward at all. Again, we're going to stabilize the pelvis while I fix the shoulders. I'm going to pull the right shoulder inferior, slightly anterior to the left. Again, the elbow is running down side by, so it's behind the midline. That's where our stretch is going to come from. I want everybody to get positioned so you can see the right PSS. Everybody see it? Now, the tip of my chiropractic index finger is where we're going to end up. Everybody have it? So I'm going to mark that with my stabilization hand. Ask the patient lift the hips up, down. Okay. So at this point in time, my thenar is on the SCP, my 10B if you will. I'm going to roll in, and here's the only working part of the move, which in real time is going to be a nanosecond. I roll in until I hook on that PSS. Joe can tell you we're hooked onto it now. I stick that shoulder superior. When I stick the shoulder superior, I shift my leg, or shift my weight where? To that straight leg. Then I just bring the knee underneath my chest. And again, he's actually held between my stabilization leg and the PSS. And then I try to bring my elbow toward my body, setting up and in. Any question on the PIX? ASCX, again, if the patient placed correctly, where will the ischial spine be in relationship to the bench? Hit right on it, right on it. Everybody have it? Okay. Now, the more tissue we have, the more tissue pull we have to take for that AS component. So, We had a lot of children in practice last night, did a couple of ASDXs. For them, I start with my hamate just barely above that ischial spine. Not a lot of tissue. I also had some larger patients last night where I had to start the ischial spine mid-forearm and take out all that S to I slack. You have to remove all that S to I slack, okay, or you won't have a chance at AS type of move, either push or pull. Would you rather err on the high side or low side? High side, because you can always come down further, but you can't back up. Everybody have it? Now again, we have to start perfect patient placement, so Joe has that hip tucked underneath, so he'll be laying on my hand. Now, the tissue pull is a little confusing when it's written in the technique manual. It says S to I and lateral to medial. I want you to think about it as S to I tissue pull and lateral to medial compression of the tissue. So you're not going to slide your hand lateral to medial, you're going to compress the tissue from lateral to medial. Because a lot of people, if they slide past that ischial spine, end up on apex of the sacrum. So S to I tissue pull and then just compress the tissue, don't slide. Looking straight. Lower hip toward me. Just a little more. There you go. Okay, lift up a little. Down. Now, here's the apex of the sacrum. I drop the plumb line down. The ischial spine is underneath his buttocks onto the table. So that's where I'm going to end up after I've taken tissue pull. Everybody have it? So I mark that with the stabilization hand. Lift up. Down. So I start superior at that point. Now let's say you lost the patient. Now keep in mind, I'm going to step away. The patient placement is holding the patient up. You're not holding the patient up. If you lose it, you can just tuck their hip underneath and save it at that point in time. You won't be able to save it at any other time. We take S to I tissue pull. Now the tissue is tight from an S to I plane. We compress the tissue. My forearms come around the bottom of the buttocks because I have to come around this direction. S to I for the AS component. The larger the buttocks, the more forearm I'm going to use. We stick the shoulder superior until I feel it stretch underneath my hand. Then, everything's frozen except for my right knee coming underneath my chest. Placing my knee just below the ischium, the shin on the angle of the knee. Come up here, and then set. This direction. Coming around the bottom pelvis for the S to I component, P to A component. And notice that as I whip the elbow, pisiform comes up for the lateral medial component. Again, it's just a natural motion if you try to bring that elbow toward your side. Any question on PIX pull, ASDX pull? The sacrum. With the sacrum, we have sacroiliac listings and lumbosacral listings. Most people get about halfway between those two vectors. So think about what you're adjusting when you intend to adjust sacrum. So if I have a sacroiliac P-L, this will be my line of drive. If I have a P-R, this will be my line of drive. Think about those joints. Now think about it. This is a male pelvis. Will that be different on the female pelvis? Absolutely. If I was doing an involved side down sacrum, this is going to be my line of drive. Involved side up sacrum, that's going to be my line of drive. So visualize that joint. We have three different sacroiliac moves. We have an involved side up push, involved side down push, involved side up pull. Preferred moves. Okay? With athletic build or a slender patient, they'll usually adjust better involved side down. For a heavy patient, let's say somebody has what we jokingly call a Milwaukee goiter, well-developed beer belly, if you will, okay, they will adjust better involved side up. Can anybody tell me why? Because if I have a heavy patient, I have all that weight laying on the down joint, what are the odds of me moving it? Pretty slim. Plus, if I have that big beer belly, I can actually hang it over the side of the bench when I roll the patient, and that will do what to the SI joint? That will open it up. Let's use another example. Regardless of body build, okay, let's say somebody's 9 months pregnant. What do you think? Involve side up, involve side down. Involve side up. You let the baby hang over the side of the bench. It actually opens up the joint. Make sure you always have mom placed towards the edge of the bench, just like we do on all patients, so the baby's never near the bench. The baby's actually hanging over the side of the bench. It actually makes for a real easy adjustment. Because due to relaxin in the joint, the SI joints move very easily with the pregnant patient. Now we also have an involved side up pull. The pull move is strictly a speed move. That's if you can't get anything started with a push, involved side up or involved side down. So think about it. Are you going to get as much depth from a pull move as a push move? No, you won't get as much depth. So you're always going to prefer a push move, for the sacrum. But pulls, you can't get anything else going, go ahead and use the speed to set it. Again, we always start with perfect patient placement. Now P-R, involved side down. I find the medial portion of that PSS. I will take tissue pull as close to that PSS as I can get without getting on it. So I want to be as tight to the joint as I can be. Everybody follow? Because we're actually adjusting the sacroiliac joint. So I take tissue pull with my stabilization hand from medial lateral. Then with the contact hand, I actually start the hand, a little bit of palm up, and then I do kind of a roll in, except it's a lateral medial roll in, get even more tissue slack taken out. My fingers are running straight up the spine so I don't contact that right PSF. Again, we stick the shoulder superior till we feel the tension underneath our hand. We're going to roll the patient toward us to a comfortable working height for us. We sidestep, place the anterior portion of my thigh and lateral portion of the patient's thigh. Then get your elbows out for the P to A. A lot of people make a mistake of having too much I to S on sacrum. You really have to bring that elbow out for the P to A component. And notice my arms up from parallel to the bench because I'm thrusting through the angle of that right SI joint. That would be Joe's line of drive. Now think with me. Joe, just help me. If I had a female pelvis, would my elbow get closer to me or closer to the table? Closer to me. Everybody follow? Right. So that'd be a P-R, involved side down. Sitting right through the joint. If you had a P-I-R, we just add torque. Lift up the low right sacrum. P-L, involved side up. We're going to roll the patient over further for an involved side up than we do for any other move. Because I have to thrust through that left SI joint. So until you have your roll, catch, thrust down, don't do this move. Okay? It could turn into a 24-inch drop move. So we don't want to lose our patient. Everybody have it? Because you have to catch the person with the lower portion of thigh. Now, with Joe's size compared to mine, I'm probably going to have my knee just below his greater trochanter. That's where I'm going to be catching with my thigh. So I don't step back further because I'll lose mechanical advantage. I want to keep as much of my body up over Joe as I can for my mechanical advantage. So P-L, involved side up. I palpate for left PSS. I take tissue pull from medial to lateral with the stabilization hand. Come in behind with the contact hand. This time we have the fingers pointing toward the table, which keeps our hand off the PSS again. If I had the hand going up, I'd have number 11 on the PSS. So I come as close to that PSS as I can get. We stick that shoulder superior again. Now I'm going to roll him over quite far. Right there. Get right up over him and set back through the joint. Set in this direction. Now if I had a female pelvis, I'd have to roll him over even further to get up over that joint. But again, notice my belly button's right up over that segment. That's where I have my mechanical advantage. So there's the P-L, involved side up. Again, he's just wedged between the bench and your thigh. He's not going anywhere. The pull move, let's get back. The pull move is we're going to come as close to that PSS as we can get without getting on it. So this will be a P-L, involved side up, pull. Involved side up, pull. I take tissue pull from medial to lateral. Come in with all 3 fingers. I can contact all 3 fingers right inside that sacrum. So we're not going to stack the fingers again. You're right on the medial portion of that joint. You're right in the sacrum without touching PSS. Bless you. Stick the shoulder superior until I feel it pull underneath my hand. Place my knee just below the ischium, the shin and the angle of the knee. Again, my center of gravity is right up over the segment. Okay, so my toes underneath the bench, get my belly button up over that segment, and then thrusting P to A. Again, we're not pulling, we're finger setting, going sideways this direction. Again, the stabilization leg is a counter force for your thrust. You're not, some people just lay the hand there and it looks like they're starting a Harley, kick down. It's a stabilization leg, not a contact leg. Any question on the sacroiliac sacrum listings? Okay, base posterior. Base posterior is a lumbosacral subluxation. So we have to be thrusting through the plane of L5 disc. Now, if you have a patient with a normal Ferguson sacral base angle or decreased Ferguson sacral base angle, they adjust easy in the side posture position. Because remember when we lay down, we loosen that Ferguson sacral base angle. But if you have somebody that has an increased Ferguson sacral base angle, you're going to be better off going to the prone base posterior that we're going to discuss in the future. Okay? So side posture is usually regular Ferguson sacral base angle or decrease. Because you have to be able to thrust that L5 joint. L5 motion, I should say. Now, tissue pull. Think back to spinography. Sacrum drops posterior and what? Base posterior. Inferior, so the disc wedge is open at the what? Posterior, so I'll take what type of tissue pull? I to S tissue pull, we're going to contact the second sacral segment. S2 is located right between the PSSs. Take a strong tissue pull, I to S. Come in with contact, take even more tissue pull. Get all that I to S slack taken out. I stick the shoulder superior. Be rolling Joe toward me to come to work height for me. Place the anterior portion of my thigh, lateral portion of the patient's thigh. Notice I get that elbow way out so I can drive as close to that L5 disc as I can get. Again, my belly button's right up over that segment for mechanical advantage, setting P to A through this plane line. Now, if I have a spondylolisthesis, which grade 1s are very safe to just say side posture because grade 1s are stable. What type of tissue pull I take with spondylo? Because the disc wedge is open to the anterior spondylo, so I'll take what type of tissue pull? S to I tissue pull. S to I tissue pull. Other than that, it's the identical setup. Still driving P to A through the disc plane line. You just change the tissue pull. So think about taking that disc and trying to make it towards a parallel, and you'll be just fine. Any questions? Make it a good day.